Hi, everybody. Welcome to this month's Simon Says Expert Series. I'm Tara Ballinger. I am a breast oncologist here at the IU Simon Comprehensive Cancer Center. While I see breast cancer patients in my clinic, my research is mostly focused on how physical function and body composition affect patients dealing with cancer, which is certainly applicable to supporting the care of patients with esophageal cancer. So I'm excited to be with both of our experts today, who will focus on esophageal adenocarcinoma or esophageal cancer, the incidence of which has unfortunately dramatically increased over the past 3 decades. Risk factors that we know about for this disease include chronic gastroesophageal reflux, something called Barrett's esophagus, having a high body mass index or obesity, and smoking. So our experts will discuss those risk factors, how we can screen for this disease, treatments, and the latest research. So to introduce our experts today, it's my pleasure to introduce Dr. Mohammad Al-Haddad. He is a world renowned in caring for patients with gastrointestinal diseases and also endosonography, which he'll talk to us about. He is a professor of medicine and is the division chief of gastroenterology here at the IU School of Medicine. Also today with us is Dr. Shadia Jalal. She leads the Esophageal Cancer Program at the Cancer Center, and she has led multiple laboratory-based and clinical trials focused on improving outcomes for this disease. She is an associate professor of medicine and is the Lawrence H. Einhorn Scholar in Oncology at the IU School of Medicine and a physician scientist at the Cancer Center. So we thank you both for sharing your expertise with us and are excited to get started. So Dr. Al-Haddad, I think we will start with you.
Thank you so much, Dr. Bollinger, and thank you, Dr. Jalal, for the kind introduction and the opportunity to be with you today and have this very timely discussion about esophageal cancer and how we can screen and prevent. This is up in the core of my practice. I'm very passionate about this. I have a few slides to share that I'm going to try to do that now. And let me know if you can see my slides. Let me make sure I have the presentation mode on. Can you see the presentation mode?
It looked good how you had it. We could only see your slides.
Okay. Sorry about that. Let me retry this again. Okay, as I'm trying to do this, you all know this is Esophageal Cancer Awareness Month. So again, this is one of the maybe the great times to discuss this with everyone, and also field any questions that you may have about esophageal cancer, or if you have any questions about reflux. Can you see my slides?
No, I don't think you're sharing.
Okay. All right, sorry about that. Let me try this again. Okay. How about now?
No, it worked the first time you did it though.
Okay.
Oh, there you go. There you go.
Okay, can you see my presentation?
Yes, if you press the slide button down in the corner, it should do your full.
How about now?
Yes, perfect.
Okay, all right. Well, as you mentioned, Tara, esophageal cancer is on the rise. And although it does not add up to a whole lot of cancers in relation to other types of malignancies diagnosed annually, it is one of those that's on the rise. And on the rise in an alarming, obviously, rate. Unfortunately, most of the patients diagnosed with esophageal cancer come at a stage which does require intensive therapy, whether it's surgery or systemic therapy with radiation and chemo. And the proportion of patients we diagnose at an early stage that's curable with minimally invasive methods like endoscopy is still relatively small. But as we know, and like every other cancer, early stages lend to better outcomes and lend to a better survival. And I'm so glad you touched on this, Tara, because we do have a window of opportunity to intervene, especially in cases of Barrett's esophagus. And why do we focus on Barrett's esophagus? Because it is probably the only precursor of esophageal cancer that we can diagnose and treat effectively and manage to prevent ultimately this becoming esophageal cancer. And Barrett's esophagus is present in approximately 1 to 2% of the population, so it's not that rare, and it's about 10 times that much in patients who have day-to-day reflux symptoms. Those are the chronic refluxers, basically. And having Barrett's esophagus, which is essentially a permanent change in the epithelium of the lower esophagus in response to chronic exposure to acid. And that happens over the course of years, obviously, and can be associated with ulcers and eventually nodularity and eventually cancer. What I would like to highlight is that not every patient with Barrett's esophagus will develop esophageal cancer. In fact, the rate of change is only less than 0.5% per year to cancer, so overall it's very low. However, it is high enough that we should continue to survey and manage these patients actively. And the best surveillance we have is endoscopy at this point. Once a patient develops some dysplastic changes in the esophagus, typically in the form of nodularity or small mass or an ulcer, that's typically an early cancer until proven otherwise. So we strive to remove that and do appropriate staging and ablate the rest of the Barrett segment at that point once we get to this plastic lesion within Barrett's esophagus. And obviously, we do have now guidelines for screening for Barrett's esophagus. Unfortunately, the uptake is relatively low compared to other types of conditions that we deal with in the GI tract. Definitely lower than what we see in the colon, for example, when it comes to screening for colorectal cancer. And this slide presents the risk factors for Barrett's esophagus. I think we touched on several of those already. I know someone cannot change the genes they're born with or the gender that they're born in biologically or their family history. However, there are modifiable risk factors, including smoking, obesity, and obviously reflux. So I will talk briefly about both obesity and reflux because there are there's some innovation there that would allow us to maybe intervene and help in effective and minimally invasive way that I may be able to highlight to the audience today. So reflux is on the rise. I think this is no surprise and no secret at this point that we're seeing a lot more reflux now than we did probably 20, 30, and 40 years ago. No one knows exactly why this is the case, but we hypothesize that lifestyle and diet may have a lot to do with it. At this point, it's fair to say that about 1/3 of the population in the US reports at least weekly symptoms of reflux. And if you extend the definition to using over-the-counter anti-acid medicines at least once in the last year, I would say you would end up with more than 60 to 70% of the population who fulfill that criteria. And symptoms of acid reflux can vary. I know most people would think of it as the classic heartburn or acid regurgitation, but it could have many other phases, including chest spasm, chest pain, of course, the non-cardiac type of chest pain, but also cough and hoarseness of voice and difficulty swallowing, and also a feeling of a lump in the throat. We call it globus, among other what we call atypical symptoms of reflux. So it's important to keep these things in mind as well. So reflux now is better managed than we ever could in the past manage it, just because we have several items in our toolbox that we can reach out to. The most common of which is diet and lifestyle. We do talk to everyone about eating healthy, losing weight, and trying to avoid refluxogenic diet as much as possible. But at some point, we move on and offer other things, including reflux surgery. And traditionally, hernia repair and fundoplication is for the longest time and remains the mainstay of surgical treatment for acid. But these days, we have other less invasive endoscopic tools to reduce acid reflux and help patients who have chronic issues from that, including what you see on the slide, on the right side of the slide. This is a cartoon of the TIF procedure. This is a completely endoscopic procedure that does tighten the lower esophageal sphincter and reduce acid reflux. It stands for transoral incisionless fundoplication. And there are several other treatments that are still in various development stages that might become available over the next few to several years to reduce the problem of acid reflux surgically. A lot of people take antacids. PPIs is probably the top agent in that family of medicines, also H2 blockers. And I know many people have concerns about the long-term safety of that. But overall, they are generally very effective tools in reducing the day-to-day symptoms that come from acid reflux, and also potentially reduce, from what we know now, the risk of esophageal cancer within Barrett's esophagus that is often driven by the presence of high levels of acidity in the Barrett segment. Now we'll touch on obesity, and this is also no surprise. It's on the rise, as you can see from this New England Journal paper that I have a picture from. Rates of obesity are on the rise for the last 3 decades, but also alarmingly, the rates of moderate to severe obesity, defined as BMI of 35 or higher, is also increasing at an alarming rate. With obesity comes a lot of problems, including long-term diseases and comorbidities that are exponentially rising, typically when someone is at the class 2 obesity, which is a BMI of 35 or higher, as you can see on the curve. And that brings a whole lot of other chronic illnesses and comorbidities to the picture. This is a risk efficacy curve of options we have that we can share with our patients in terms of management of excessive weight, including the low risk but also low efficacy interventions like diet and exercise. And nowadays we have access to wonderful medicines that actually have a lot of efficacy, including things like semaglutide and tirzepatide that are available for diabetics and for those who are wishing to weight loss. Moving up the curve, we have endoscopic weight loss options, including balloons and endoscopic suturing that reduce the size of the stomach and lead to weight loss. And obviously, on the highest part of the curve, the riskiest but the most efficacious are the traditional weight loss surgeries that people know about, including surgical sleeve gastrectomy and Roux-en-Y gastric bypass. This is just a few examples of what we have now in the endoscopic weight loss realm of work, including balloons that are either saline filled or gas filled that allow weight loss. Also the suturing system that I'm showing in the middle part of the slide, where we plicate the wall of the stomach to shorten and make the gastric capacity smaller. There are other new technologies in various stages of maturity, including ablation and resurfacing of duodenal mucosa, among other things. Unfortunately, most of these, if not all of them, are not covered by insurance at this point. Unfortunately, obesity is not regarded as a chronic illness yet by major payers, and therefore most of these are available only on a limited basis, out-of-pocket or cash basis at this point. Which leads to the unfortunate conclusion that most people who struggle with weight issues do not have access to effective treatment strategies. In fact, under 5% of those who have weight problems have access to any sort of management at this point. And even 1% or less of those who are in need of that have access to the most efficacious of which are endoscopic and surgical weight loss options. Now, after covering some of the risk factors for Barrett's esophagus and esophageal cancer, I would like to discuss where we stand as societies in GI and as practitioners in GI on the screening of Barrett's esophagus. Not many people know this, but there are existing guidelines to screen for esophageal cancer and Barrett's esophagus. So if you are a male with chronic reflux lasting at least 5 years, where you're having at least weekly symptoms, and then you fulfill 2 other criteria, including being white or over the age of 50, or having abdominal or central obesity, where the waist is over 102 centimeters, or if you have any history of smoking, whether current or past, and or family history of Barrett's esophagus or esophageal cancer, then you do qualify for screening. And right now, the best screening you can get is endoscopy. And I'll touch on other upcoming modalities for screening. But right now, if you fulfill these criteria, again, being a male with chronic reflux and 2 of the risk factors, then you should talk to your doctor about getting an endoscopy. And what do we see in endoscopy and reflux? We see a variety of pathology. Obviously, we touched on Barrett's esophagus, but also a lot of acid-related damage to the epithelium, including ulcers, strictures, and potentially even cancers that may not be quite visible from the beginning. And we ultimately, what we do once we see a lot of inflammation, we treat that with antacids and PPIs and ask patients to come back and get another look after 3 months once the inflammation is down to rule out the possibility of an early cancer. So once we have identified Barrett's esophagus, what we do is we place this patient on a surveillance program where they come back every 3 to 5 years to examine the Barrett's, take some random biopsies to check for dysplasia. If we identify any nodules, ulcerations, or lesions within the Barrett's esophagus, those are, until proven otherwise, early cancers, and we have to remove them. And the way we remove them is endoscopically, typically, because we discover them at an earlier stage, being part of the surveillance program that we have for Barrett's. And once we remove those nodules, we ablate the rest of the Barrett's esophagus using either radiofrequency ablation methods or cryotherapy, which is essentially freezing, which is remarkable because it does replace the Barrett's epithelium with normal squamous epithelium again, which is the ultimate goal of any treatment of Barrett's esophagus. So how do we remove these early cancers? And now it's fair to say that every lesion in the T1 stage, which is the earliest stage of esophageal cancer that is confined to the wall of the esophagus, might be a candidate for endoscopic resection. Obviously, we do our due diligence with things like PET scans, endoscopic ultrasound to make sure that we are removing a lesion appropriately for that matter. And we can start with EMR for the smaller, more superficial lesions, endoscopic mucosal resection. But then if there's a larger lesion, a deeper one maybe, we employ endoscopic submucosal dissection, which has been increasingly available. And we've been doing many more of those in the last few years than EMRs, at least in the higher risk lesions, where we remove the entire segment that has the lesion with free margins in one piece, or unblock as we call it. So that will offer a great pathological staging, but also potentially a complete cure of that early cancer. Obviously, when tumors exceed a certain depth of invasion, we cannot offer endoscopic resections anymore, and we refer them to surgery. Many of these patients get neoadjuvant treatment initially to downstage the tumor, and those who are surgically fit eventually end up with esophagectomy for the more advanced stages. This is an example of an ESD case I did last year. There was a nodule with an ulcer in the left upper side of the slide. And we proceeded with ESD, removing this lesion and block as a whole. And if you look at the left lower side of the slide, you'll see the mass and a surrounding rim of normal tissue. And this lesion had a negative margin both on the deep and the lateral side. So this patient technically fulfilled the criteria for a cure with no lymphovascular invasion, and and it was moderately differentiated adenocarcinoma. For those of you who think they qualify for a Barrett screening, but they're afraid of endoscopy, I'll tell you at this point, we're still offering endoscopy as the main modality for screening. However, in the next 5 to 10 years, I do expect a multitude of technologies to be available for screening for Barrett's, including possibly blood, serum, and stool biomarkers, or maybe a capsule endoscopy, which is presently available. It still doesn't perform great, but it will likely improve technologically over the next few years, where you swallow this, it's essentially a capsule with a string, you swallow it, it takes pictures like a movie basically, and then you pull the string back and it comes all the way through the esophagus one more time, taking images and screening for Barrett's. There's also a sponge that the patient can swallow on the way down, on the way up. This sponge essentially will rub against the wall of the esophagus, scraping cells, and once the sponge comes out, we can do an analysis on the types of cells stuck on the sponge and see if there's any evidence of Barrett's esophagus or cancer. So a lot of things are coming. This is an area of intense development as far as technology goes, so I do expect great options to become available for those who do not want to undergo endoscopy, at least for the initial screening part of Barrett's esophagus. And this is my last slide. Thank you for giving me the time to share that with you.
Awesome. Thank you very much. And I think we'll just go right to Dr. Jalal, and then afterwards we'll move on to questions that we've gotten. So Dr. Jalal.
Okay, let's see if I can do this faster than okay, am I sharing anything? Let's try now.
I
okay,
see
yes.
Your slides are not yet on
I'm gonna swap I believe I was just shown how to do this.
There you go.
Okay, am I sharing my presentation mode?
It looks good.
Okay, good. Okay, so Dr. Al-Haddad mentioned some of those things, but obviously I'm very passionate about esophageal cancer. I think it's one of the most important cancers, and there is power in numbers. Esophageal cancer has both a global and a local impact. Worldwide, it is the 7th in cancer incidence and the 6th in mortality. There's more than 500,000 cases worldwide of esophageal cancer right now. And in Indiana, locally, it is one of the top 10 causes of cancer mortality, specifically in white men. Dr. Al-Haddad covered some of those things, but I think it's really important to remember that esophageal cancer is not one disease. And if you're talking about esophageal cancer in the United States, you're talking about adenocarcinoma, which is the one related to Barrett's esophagus and reflux. And as he mentioned, all the risk factors, I do want to stress that it is really more a disease of men than male to female incidence or ratio is 9:1. And the median age is in the 60s. So it is a cancer that affects men that are, relatively younger. On the other hand, if you are in Asia or China and talking about esophageal cancer, they are thinking about squamous cell cancer of the esophagus, which is a completely different disease. And to further complicate things, if you talk about squamous cancer in the United States, it's mainly related to smoking and alcohol. And if you're talking about it in Asia, it's actually related to diet and some nutritional deficiencies. If there is a disease that I would say needs a team, it is esophageal cancer. It is the multidisciplinary approach that makes a difference. While I, as a medical oncologist, help patients navigate and make a lot of the decisions, I cannot function without my thoracic surgeons, without my gastroenterologists like Dr. Al-Haddad, without radiation doctors. I cannot function or give my patients good care without nutrition and supportive care. The Precision Genomics program, the MOVE program, which Dr. Ballinger leads, which I'll talk a little bit more about, and obviously discussing smoking cessation. Dr. Al-Haddad discussed how you can do endoscopic treatments for early stage esophageal cancer. He also explained that unfortunately, the majority of patients present with locally advanced disease. Esophageal cancer is one of the smartest cancers. It's one of the top 5 smart cancers, likely because it develops after decades of DNA damage by reflux to the esophagus. What that means is that at presentation, a lot of times it has already grown through the wall or a few layers in the wall of the esophagus and has involved lymph nodes. So in the past, we mainly had radiation or surgery, but that was really not curative in patients with locally advanced disease. So then we learned the role of adding chemotherapy to radiation. We went on to learn the role of adding surgery to chemotherapy and radiation. And 2 years ago, almost exactly, we learned the role of giving adjuvant immune therapy for a year in patients who you take to the operating room after you have given them chemotherapy and radiation, and you find out that in the surgical sample, there is still evidence of cancer. I won't take you through the whole history, but this is one of the landmark trials. And it's actually not surprising that it comes from the Netherlands, because in the Netherlands, they have one of the fastest rising incidences in esophageal cancer incidence rates. And this is a study that basically compared patients with locally advanced esophageal cancer. They either received surgery alone upfront, or they received chemotherapy with radiation followed by surgery. And there was an improvement in survival. When you treated people with chemo and radiation first, you were less likely to find cancer in the surgical sample. And more importantly, we did not increase the rate of surgical complications by giving people chemo and radiation first. And this is something that we have to stress to patients. Sometimes my patients say, just take it out. And we have to understand that that is not the right thing for esophageal cancer. You really need, most of the time, the chemotherapy and the radiation first. As much as I hate to say it, while surgery definitely has been believed and shown to increase the cure rates following chemotherapy and radiation in stage 2 and 3 esophageal cancer, and we have shown this last year or so, we did a national cancer database retrospective analysis, and we showed that surgery improves outcomes in every stage 2A, 2B, 3A, 3B. We, however, know that surgery is a major surgery. Esophagectomies, you can't just go in and take this little tumor out. You have to remove a good part of the esophagus, part of the stomach. The esophagus, it's like a highway. There's lots of lymphatics and soft tissue. There's lots of lymph nodes, and you have to do a full resection. You have to have relatively wide margins in the proximal area and the distal area. And after you do that, you pull the stomach up and it becomes, kind of in the chest. And there is just no other way around it. While I frequently send my patients to get chemotherapy and radiation closer to home, I stress the importance of doing surgery at a center like IU. We know that it matters who performs your surgery and where it is performed. It's not just about the surgeon being experienced, but about the center being high volume, because surgery is more than you just do the surgery. It's all the post-operative care that you need. And what we know is you are more likely to have a complete resection. You have a lower reoperation rate. You have a higher number of lymph nodes removed, which is both a treatment and a prognostic tool, meaning it tells you what's the likelihood cancer would come back. It all depends on how many lymph nodes are still positive after daily radiation and weekly chemotherapy that was done before surgery. It also means better short and long-term mortality. And, I'm grateful that at IU, we have excellent thoracic surgeons and we are a high volume center. And there's no doubt that it takes time to recover from surgery. I think for most people, it's probably, 6 to 12 months to really get their quality of life better and kind of closer to baseline. Mortality is very low, probably 1 to 2%, but there are some other chronic, I would call them outcomes, maybe not complications, because they are just related to some of the functional changes that occur when you remove most of the esophagus. Patients can have some gastroesophageal reflux disease. That stomach, the conduit might not function appropriately. They might feel full quickly when they eat because they have to eat smaller meals. Potentially they could heal with a stricture or a narrowing. And just like any major surgery and any surgery you do for cancer, think about the depression, the sleep disturbance, the psychological stress that occurs. Patients can have dumping syndrome, especially in the first couple of months while their system adjusts to eating and then, immediately having to go to the bathroom because they have diarrhea or cramping. And think about all the financial toxicities, the cost of all of those interventions, and the time you take off work to heal and recover from all of those things. Perhaps nothing has really impacted the world of cancer in general recently the way immune therapy has. And immune therapy does play a role in the treatment of esophageal cancer. And in esophageal cancer specifically, it is what we call the programmed death pathway that has really changed how we treat the cancer today. And it's kind of a simple, this is a simple cartoon where we have your tumor cell and then you have some of your immune cells here. And specifically, we're going to focus on your T cell. And what we know is that there is this interaction. Our T cells have a receptor or an antenna that cancer can bind to on the surface of the cancer. It can express or overexpress the ligand that can bind to this receptor. And it is called the programmed death because that's simply what it does. Whenever our tumor cell interacts with the T cell, it sends a programmed death signal and the T cell goes to sleep. And that's one of the ways through which cancer is growing and spreading while your immune system is basically asleep. And when it comes to immune therapy in esophageal cancer, almost all of the agents that we use are what we call programmed death 1 pathway blockers. And what they do is they prevent that interaction. When you stop sending that immune cell this negative signal telling it to sleep, it wakes up and it fights cancer. So 2 years ago, the FDA approved adjuvant immune therapy, specifically the drug nivolumab. It was approved based on this large study that basically compared patients that had chemotherapy and radiation and then had surgery. All these patients had to have still residual disease. We took everything out. We did that on-block resection, but in that surgical sample or in the lymph nodes, either in the esophagus or in the lymph nodes, we found there was residual cancer that has survived the chemotherapy and the radiation. Those patients were randomized to receive adjuvant immune therapy for a year or not. And that study showed that nivolumab for a year doubled the disease-free survival and reduced the risk of dying from cancer by 31%. And at Indiana University, I wrote and designed a study that we ran through the Big Ten, and it was a smaller study. It was not randomized, but we did a very similar thing. We gave a year of immune therapy. In this case, we gave a drug called durvalumab, and we really saw some better results than what was thought, to be seen in the historical control. And we did a lot of, fancy scientific things and translational studies to try to better define who is that group of patients that would benefit from the immune therapy. And we are taking this a step further because while we are improving outcomes, they are not where I want them to be as a patient. So the cooperative group trial, ECOG, has actually run this trial. Right now it is on hold because it has fully accrued, and we are analyzing the results. 278 patients were enrolled. We participated in it at IU, and this study takes that question of immune therapy a step further. And not only are we giving immune therapy after surgery, but we are also randomizing patients to get chemotherapy with radiation and immune therapy, or chemotherapy and radiation alone first, followed by surgery, and then everybody gets immune therapy. And if the study, we're waiting to see what the results of the 278 patients are like, but if it does seem to be positive, a larger phase 3 trial will occur to confirm this. Unfortunately, I think we still have a lot more work to do in esophageal cancer to know our enemy. We still do not necessarily understand what are those drivers, what are the genes that are impacting the growth and the progression of esophageal cancer. And unfortunately, while we are making some progress, we are not where we need to be. But in the past, esophageal cancer just looked like this big pie on the left where it's all the same disease and it's homogeneous and it's the same color. And now we know that we have subsets of esophageal cancer. We know we have this P53 group, we have the CDH1 group, and so on and so forth. And we're starting to define what are those genes that basically are driving specific subsets of esophageal cancer. And at Indiana University, we refer patients to the Precision Genomics Clinic routinely to basically try to better understand the biology of their disease. But I'd like us to see where lung cancer is today. When I started a long time ago treating lung cancer patients, we didn't have this pie chart. For us, it seemed like you had one of two kinds of lung cancer, and then we understood, non-small cell means a lot more than non-small cell, but now we know that basically lung cancer is a bunch of diseases, and unless you know what you're dealing with, you cannot appropriately treat patients. And that is really where we are trying to take the field in esophageal cancer. So we are starting to understand things, and right now, as it stands, if you remember, I said there's squamous cell cancer of the esophagus, and one of the challenges in esophageal cancer is for the longest time, the trials enrolled both squamous and adenocarcinoma. Imagine enrolling two different diseases on the same study and trying to figure out if what you're doing is working or not. Well, based on genomic results, we now understand that a squamous cell cancer of the esophagus is more like a head and neck cancer. So we no longer include those on the adenocarcinoma studies. In fact, each of these two diseases of esophageal cancer have their own staging system. So we did get that. But we also now know that in adenocarcinoma, so far we have 4 different subsets, and we are probably going to soon be treating them differently. This microsatellite instability subset specifically, which is relatively rare right now in esophageal cancer, it's around 4 to 7%. This group of patients seems to be highly sensitive to immune therapy. But, most of what we see right now is what we call chromosomally unstable, where they have P53 mutations. They have the toughest cancer to treat, and we still need to do much better to really better define those treatments. So this is what esophageal cancer treatment looks like today, and you're not supposed to memorize this slide, but what I would say is there's a lot more than chemo. We need to know now, once we know somebody has esophageal cancer, do they have that microsatellite instability high subset? You're going to treat them differently. And if they don't, do they have HER2 amplification? If they do, this opens up a whole number of targeted agents. And if they do not, most of those patients are actually receiving chemotherapy with immune therapy when they have metastatic esophageal cancer. And there's definitely been progress with adding immune therapy, not only after chemotherapy, radiation, and surgery, but also to chemotherapy in the metastatic setting. And progress, I think, happens daily. This is the newest kid on the block. It is not FDA approved yet, but soon we are going to be testing patients for what we call Claudin 18.2. This is a protein that can be overexpressed on some esophageal cancers. And just a couple of months ago, this study was presented at a major meeting. And in that trial, patients were basically randomized to receive chemotherapy, either alone or with zolbetuximab, which is basically a drug that targets Claudin 18.2. This was the study, and patients all had to test positive. We tested their tumor tissue. We had to ensure there's moderate or strong staining in 75% of the cancer cells, and patients had to be HER2 negative. And this adding zolbetuximab to chemotherapy did improve what we call progression-free survival and overall survival. It caused nausea and vomiting. This is not FDA approved yet. And unfortunately, the way things happen, you design a study and you run it. It takes years to run the study. And in the meantime, the standard of care has changed. And as you notice on this trial, you did not get immune therapy with chemo, but now immune therapy with chemo is the standard of care. So the question remains, where is this going to fit? Maybe in a patient that you can't give immune therapy to, we will have to wait and see. Well, I am a big believer in drugs and taking care of patients and giving them the right medications. I cannot explain how important it is to take care of the patient as a whole, treat their depression and their anxiety, and more importantly, treat their nutritional needs. This is Beth, our dietitian, who sits next to me in clinic, and the dietitian is your best friend. You cannot take care of esophageal cancer patients without dealing with their nutritional needs. Most of them present with dysphagia, trouble swallowing, and they have to do dietary modifications, and they can't find the right food to eat. They sometimes need stents, which Dr. Al-Haddad places, or dilatations, which Dr. Al-Haddad does. Sometimes they need a feeding tube. And then as you give them chemo and radiation, you make them a bit worse before you make them better. You inflame that esophagus. And again, you got to support them. You got to give them the pain medicine and the IV fluids and help them with those dietary modifications. And once they have surgery, you got to teach them about dumping syndrome and early satiety and explain to them why they have to eat small but frequent meals, and so on and so forth. So patients need a lot of counseling when they have esophageal cancer every step of the way. I'm also a big believer in exercise. And this is actually why I asked Dr. Ballinger, my friend, to moderate this talk, because while she is a breast cancer doctor, she really is one of those physicians that really understands the value of exercise. And there was the study that was specifically in esophageal cancer that randomized patients. They either got the regular treatment plus regular exercise. They chose to exercise or they didn't choose to exercise, or they were randomized to a schedule. They exercised 3 times a week and they worked with an exercise specialist 2 times. And they measured lots of things. And while we know, their fitness, probably their cardiopulmonary fitness was better. And while we might guess that they did not lose as muscle mass during chemotherapy as the group that didn't exercise, they also were more likely to complete their chemotherapy. And I think if we do those trials and we explain to patients why they need to have exercise, it goes along with your chemo. It goes hand in hand with your chemotherapy. I think patients are more likely to do this. So this is why we have the MOVE program, and we refer all our newly diagnosed esophageal cancers, patients that need chemotherapy and radiation. They get seen, they get an assessment, they get some patient-reported outcomes evaluation, and then they either get physical therapy, they get referred to some of our rehab doctors that mainly see cancer patients, they get an exercise program, and they get a lot of other things. And they can be seen every phase of their treatment because their needs might differ. So if I was to end, I would say, work is needed on multiple fronts. April is Esophageal Cancer Awareness Month, which is why we are having this session, because our number one job in the medical community is not to judge, but to educate and raise awareness. And the truth of the matter is, for some patients, esophageal cancer is preventable. Lifestyle modifications, not smoking, reducing, late night eating, avoiding reflux, those are things that are important. I think prevention is very important. And if you have some of the risk factors, Dr. Al-Haddad said, you should be screened. You need to, discuss that with your primary care doctor and potentially undergo that endoscopy. Early detection helps. And then as we treat patients, we still need to take care of them after they have conquered cancer. There are some long-term things that we need to focus on. Unfortunately, the treatment of esophageal cancer is not convenient. And in my opinion, both quantity and quality of life should be our focus. We still need to do a much better job to make treatment more convenient, reduce the toxicity, including the cost. And we can't do anything if we don't understand the biology of the cancer. As in the end, while stage is important, biology is destiny. So whenever I see an esophageal cancer patient, I think of my uncle. My uncle was in his late 50s when he died from esophageal cancer, and he was a remarkable man. He was a physician himself, a urologist that did one of the first most successful kidney transplants in Jordan, back home where I come from. He worked late. He'd come home at 10 p.m. and he would eat dinner. He was not a smoker or a drinker, but unfortunately he had reflux. He never got a screening endoscopy, never knew he had Barrett's esophagus, and he died from esophageal cancer. And I hope as we raise awareness that his story does not happen as often. Thank you so much.
Thank you so much for that. I think this has been a great presentation, going all the way from prevention and screening all the way through to supporting patients through their treatment and end of life. A question that came up commonly from a lot of our viewers was about the long-term use of PPIs or Nexium, Prilosec, as we more commonly know them. And how we balance reducing reflux and risk of cancer with other long-term cancer risks that may or may not be associated with those drugs. So Dr. Al-Haddad, I don't know if you can comment on that long-term risk associated with those medications.
Sure, that's a great question. And you all know how difficult these studies can be to conduct and establish causality between a risk factor and an outcome, especially under the circumstances where you have multiple other risk factors besides reflux concomitantly working together. Our general rule or general guidance, I guess, on PPI use is use the minimum effective dose for the shortest possible time. I think this is a very safe statement to say at this point. The long-term effects of PPIs are still being studied. We don't have great data on them. But out of all the things I hear about from my patients, and I hear about laundry lists of side effects and problems that come with PPIs, the ones I probably subscribe to the most are metabolic bone disease due to lack of absorption of magnesium and calcium, pneumonia, and C. diff colitis. I think there's enough literature on those to make the statement that heavy long-term use of PPIs will probably end up leading to things like back fractures and hip fractures and colitis and pneumonias. The ones I don't really know if there's much to support are the kidney disease and the dementia. I get asked this question all the time. I don't know if we have enough to say that PPIs cause these. And cancer is in that category. There isn't really enough to say that PPIs will give you a carcinoid of the stomach, like has been previously shown in some of the animal models, because it has not been really noted in humans. So I guess it doesn't rule this possibility out completely, but I would say if you're known to have risk factors for esophageal cancer or Barrett's esophagus, today, the risk of not taking a PPI and letting the acid do its thing in your esophagus probably outweighs the long-term side effect from PPIs. Yeah. If you can get by using an H2 blocker like, Zantac or Pepcid, that would be even better. But most people do require PPIs.
Okay, great. And Speaking of risk factors, Dr. Dr. Jalal, maybe you can comment on what we know about esophageal cancer in families, whether it's hereditary, whether it's associated with certain genetic mutations. Do you recommend that your patients talk to their children at all about esophageal cancer, or how do you handle that?
I would say for the most part, esophageal cancer is not a genetically inherited disease. Now, there are certain genetic abnormalities that increase your risk of cancer in general, right? So there's this thing called Lynch syndrome or Li-Fraumeni syndrome, and these patients have a higher risk of multiple cancers, and esophageal cancer could be one of them. But I would say in general for esophageal cancer, it's not the story of, for example, the BRCA1 gene and breast cancer. We don't have these strong associations. There are some studies that show, especially in younger esophageal cancer patients, if you test them, around 10 to 15% of them will have what we call a germline mutation. So something that they didn't necessarily inherit. It could be sporadic or random, right? But it is in their normal DNA. But I would say that those by themselves do not seem to mean you definitely get esophageal cancer. For a lot of patients, it's potentially an interaction. The environmental risk factors are very important. So I would say for most patients, it is not genetic. Now, there is sometimes familial clustering. Dr. Al-Haddad could potentially talk about that, for example, in Barrett. And I always think of that potentially as you sit together around the dinner table, you eat the same food, you have the same eating habits. So you all tend to, develop a certain thing. But it's more because as a family, you're hanging out together.
And do you ever, I know in breast cancer, there are medications that we sometimes use that target some of these more common cancer-associated genetic mutations. So although there's not clear association between those mutations and esophageal cancer, are there, one question that was asked is whether there are clinical trials looking at medications that target some of those genetic mutations? Because there are esophageal patients that have BRCA or other mutations.
Yes. And so actually I wrote a study that we basically just unfortunately suspended. And that was basically in patients. There's around, if you look at the data, 30 to 40% of patients with esophageal cancer, if you actually test their tumor tissue, and then around 10% if you test their normal cells, they potentially have what we call a DNA repair mutation. And so we gave patients a DNA repair inhibitor, a drug called niraparib. And unfortunately, by itself, it did not seem to have any activity. Now, I think, that doesn't necessarily mean this technique or this approach will not work in esophageal cancer, but I think there is just a lot more work that needs to be done in the lab, to be honest with you, to really understand how to handle those mutations and what their impact actually is, if any, on cancer progression and development. But there are a lot of clinical trials going on in esophageal cancer. We have a very active phase 1 program, and I just showed some of the immune therapy trials that we're doing. So there's definitely a lot of research going on in general.
Yes, we definitely need more. And going back again to early detection, there were a few questions about early symptoms, both of acid reflux and esophageal cancer. So Dr. Al-Haddad, I know sometimes people can have a lot of congestion or kind of a chronic cough. That's sometimes their only symptom of reflux. How would someone go about determining if they may have reflux as a cause of some of those kind of upper respiratory symptoms? And why is that happens?
That's a tough one. I can tell you this time of the year, everyone is either having a postnasal drip or sneezing or having a lot of throat clearing type of symptoms. I think it depends on the pre-test or baseline risk based on the profile of a certain person or a patient. Most of the postnasal drip symptoms are probably not acid related at this point across the board. However, if you're looking at a specific person who does fit some of the other criteria with higher risk for Barrett's, chronicity of symptoms, lack of seasonality of symptoms, diet-related exacerbations of symptoms, all of these weigh in on whether or not we would want to take this more seriously, as in put someone through an endoscopy or not. And I think given where we are with the alarming rates of GE junction and esophageal cancers, we often end up lowering that bar for detection, for endoscopy, even though we'll end up with many negative or false alarms, as we call them, endoscopies. We would still want to detect that maybe 1 in 50 or 1 in 100 that has Barrett's esophagus. And I can tell you, we diagnose Barrett's daily in our endoscopy lab. And we have a very robust registry for Barrett's, and also we've been doing a lot of endoscopic therapy for more than 25 years. So we do a lot of that as part of our screening and detection. And guess what? We are finding more Barrett's. I mean, there's no question that it is more common now than 20 years ago that you would scope someone with even occasional reflux. And the problem with some of the reflux symptoms, that they're not specific, they could be completely absent, especially in men. Men don't tend to have a lot of heartburn, and they live through their days and don't even think. And you would put a scope down and find horrible esophagitis and a long segment of Barrett's, and they had no idea that this thing is happening to them. So again, it's a tough model to kind of fit, but I think we would want to definitely be more proactive than reflexive when it comes to detection.
Mm-hmm. So I think, and I'll welcome each of you to share any closing thoughts, but for me, I think this is all very similar to our story across all the different cancer types, that it's important for patients to be advocating for themselves. This is a less commonly screened for cancer, so something to ask your physician about. But then if you are dealing with esophageal cancer, there's a lot of hope on the horizon for treatments that we're coming up with. And again, advocating for yourself for some of those supportive care services to help you in your journey. Thank you both for sharing your expertise with us, and thank you everybody who participated in our Simon Says series today.
Thank you so much.